Okay, great. Thanks everyone for being here. Let me see. Is it this? Okay, great. So let's talk about myopia and the treatments for it. Let's see. Sorry, I don't know how to use this. Oh, okay, now it went. Okay, there was just a little delay. Okay, so I don't have any financial disclosures, but I do need to mention I'll be talking a lot about atropine, and it's not FDA approved for the treatment of myopia. Okay, great. So let's start out talking about the scope of the problem with myopia. Up to 50% of the adult population currently has myopia, and the prevalence is increasing. This has been known for many years. You can see the difference between in 1971, it was about a quarter, and in 1999, it was already 42%. It is more common in Asia. We have some numbers here for in Taiwan and Singapore, 20 to 30% of 6 to 7-year-olds are already myopic, and 84% of high school students. And you could see how the numbers vary internationally, but specifically if you're looking at East Asia, those numbers on the top there, and to note that 24% of the myopic population in Asia will become highly myopic as adults. So you may think, okay, maybe that's not such a big deal, especially for the pediatricians in the room. Let's just talk briefly about why this is a problem. Potential complications of myopia include premature cataracts, include retinal detachments. So you can see how the numbers really change. So for the more typical population or those with less myopia, the yearly incidence of retinal detachment is only 0.015%. But as your level of myopia increases, it goes up first to 0.07% and then all the way up to 3.2% per year for those with more than 6 diopters of myopia. Macular choroidal neovascularization, you can see the rates, 2 times increased rates for low myopia, up to 9 times increased rates for the higher levels of myopia. Glaucoma, 4% of patients with low myopia, and it's just slightly more with high myopia. I put this chart off to the side so you can see the typical population level. Sorry, I don't think it's coming out that well, but maybe around 1 to 2%. And these rates of pathologic myopia, which is really what we're trying to avoid, the global prevalence is somewhere from 1 to 3%, but this is the cause of low vision in about 6 to 8% of Europeans with low vision and 12 to 30% of East Asians with low vision. So these numbers are really just enormous. So that's why we're going to spend some time talking about what could be maybe done to prevent this. The earlier onset of myopia leaves more time for the progression at higher rates and to higher myopia. And to think about this a slightly different way, the socioeconomic burden is estimated at $268 billion worldwide of myopia. So this really needs to be addressed. Just a moment on the genetics. So there is evidence for heritability of the non-syndromic forms of myopia, which is mostly what we're talking about, like not Stickler syndrome or those other things that go along, but just the regular myopia, and especially high myopia. And there are 20 associated loci that have been identified. But the current rise in the prevalence is especially interesting because of this unusual pattern where the prevalence is so much higher, especially starting around age 11. So this does seem to be acquired. There are some theories. Why is this happening? And the 2 main theories are outdoor versus indoor time and near work. So let's talk about both of those. Studies in Singapore and Australia have shown the total time kids spend outdoors is associated with less myopia. So more time outside, less myopia. And it was, there's some clarity that we still need about why does this happen. Is it because those kids are inside and they're reading and they're doing a lot of near work? There's a lot of confounding between the near work and the outdoor time issues, but these studies show that it was independent of the indoor activity, if they're reading or if they're participating in sports. Chinese children in Singapore and Sydney had a 2% reduced odds of myopia per additional hour of outdoor time each week. The time outside can reduce the effect of having myopic parents and of increased amounts of near work. So this does seem to be very important. The mechanism is really uncertain, but it seems to be related to the bright light exposure, which I'll get into in detail with some studies later. But the bright light may stimulate dopamine release, and it may inhibit the axial elongation. For the pediatricians, that has to do with the eyeball itself actually getting longer. The UV exposure is not needed, so as I recommend this to my patients and their families, we talk about, skin protection, eye protection, that's all fine, sunglasses, whatever, it's okay. You don't need the actual UV exposure. It has to do with the intensity of the light. So I wanted to show these because I thought this was so interesting, especially in China especially. They're really trying to target this problem in whatever way possible. So this pilot study has been done by making the light in the school more similar to outdoors. And you can see how it's all windows around the classroom. So they're getting as much light into the classroom as possible. And then another recent study, this was in the last issue or two of Ophthalmology. They looked over a year at 930 students in 16 schools, and the children were encouraged to go outdoors for up to 11 hours a week. And this actually reduced the myopic change in both myopic and non-myopic kids. In those with shorter outdoor times, they really needed the higher bright light intensity, so the less time you needed to be extremely bright, but even a longer duration with moderate light may also have protective effects. So really just outside as much as possible. That's what I really want to impress upon you with all this. It's very important, has been well established. The near work is less convincing. The results have been somewhat equivocal. You can see in the chart, I know everything, it's very small, but I really just wanted to show that they're sort of hovering around the line because not as convincing. But one meta-analysis did show that more time on near work was associated with higher odds of myopia. And their conclusion was that the odds of myopia increased by 2% for every 1 diopter hour or more of near work per week. The intensity may be more important than the total hours. There are also seasonal variations, which also ties into all of these things. The refractive error and the axial length progress less in summer than in winter. When there's more light, kids are spending more time outside. This was studied both in a Chinese cohort and in an ethnically diverse cohort. So that's a background on myopia, the problem, the theories of why it's happening. So let's talk about what we can do about this. There was a 2011 Cochrane review, and you can see all of these treatments were studied. Undercorrection, multifocal glasses, these different novel lens glasses, bifocal or multifocal contact lenses, orthokeratology, topical timolol, and these topical antimuscarinic agents. And their conclusion, which we'll get into the details in a moment, were that antimuscarinic agents are the most likely effective treatment to slow myopia progression. Similar review from the pharmacology literature. They pretty much studied all the same things and came to a very similar conclusion. I want to discuss each of these briefly so that we all know what I'm talking about here. So undercorrection, where you give less than the full myopic correction, the idea is it achieves myopic defocus, which did reduce the progression in animal models and thereby reduces the stress on accommodation. But it's been shown to increase or have no effect on progression. And importantly, that first part I said that it could increase progression. So this really should not be used. The kids should be getting their full myopic correction that they need based on their cycloplegic refraction. Next, multifocal eyeglasses. So these were given progressive addition, progressive add lenses, and it did have a small treatment effect, but not clinically significant and only 0.2 diopters different. So probably not worth it. Bifocal glasses. So the idea was that bifocals could decrease the retinal defocus, leading to less axial growth, but randomized controlled trials in the US, Finland, and Denmark showed no significant effect. One study in Chinese Canadian children did show some slowing of the progression. Contact lenses. So there's a randomized controlled trial which showed that soft contact lenses and the rigid glass permeable, that's the hard contact lenses, were not effective. And the contact lens and myopia progression study did show a difference in the refractive error, but there was no difference in the axial elongation, so it's thought that it's just changing the shape of the cornea, which is really not what we're going for. want to spend a moment on orthokeratology, sometimes called Ortho-K, because I've heard that locally this is more in vogue than it is in New York, where I'm coming from. So the patient wears these reverse geometry lenses overnight to flatten the cornea, and you can see what happens in the image on the top. The idea is that it provides clear vision during the day, and the reduction in myopia is achieved by central corneal epithelial thinning and mid-peripheral epithelial and stromal thinning. There has been a meta-analysis of 7 studies which did show the reduction in myopic progression by 45% after 2 years. This may work with this peripheral blur, which seems to be important, so it corrects the central refractive error so you can go about your business and see everything you need to see, while the periphery is blurry so that it doesn't, lead to the axial elongation. And this does seem to work. However, the kids are wearing their contact lenses all night, every night, and there have been cases, a significant number of cases of severe microbial keratitis related to Ortho-K. This is just the image from the paper that I have on the top right. This scar is not going anywhere. So let's really keep that in mind before recommending Ortho-K. Pirenzepine, which is a selective antimuscarinic agent, did work, but there's this the kids had a lot of difficulty with accommodation. They had mild mydriasis. This is not available, so we're going to move on. The World Society of Pediatric Ophthalmology and Strabismus has put together a position statement on this and sort of summarizing everything. So under correction, like I mentioned, I just want to say again, please don't do that. It doesn't work and may be counterproductive. Probably does not work. The bifocals, progressive lenses, and the regular contact lenses, they state that Ortho-K might work and this peripheral retinal defocus, but came down as in the does work column is just the atropine drops. So let's spend the remainder of the time talking about that. This has been used for many years. It was actually reported an improvement in myopia after atropine use in 1868 and 1871. So this is not new. When I talk to patients about this, there's a lot of, there's some hesitation because it's not approved by the FDA and you can't just get it from your pharmacy across the street, but we should know this is not new and has been used for a very long time. How does it work? It was initially thought to work by blocking accommodation, but animal studies have actually disproved that theory, because if you section the optic nerve or lesion the Edinger-Westphal nucleus, it does not inhibit the development or the recovery of myopia. Maybe it acts on the extraretinal muscarinic receptors, maybe in the RPE, choroid, or sclera. It may boost dopamine release, which I had mentioned as part of the way the outdoor time and the light might work, and that may control the eye growth. Maybe the dilation results in increased UV exposure, maybe. Also, the myopia may be associated with increased chronic inflammation that we don't see, but is actually there, which atropine may be downregulating. We don't know, but studies of how it's used have shown how effective it can be. So the main study is this series, the atropine for the treatment of childhood myopia, the ATOM study. So the first one was in 2006. So randomized, double-masked, placebo-controlled trial, and there were 346 of the 400 initially enrolled children completed the study. 2 years. Atropine 1% versus placebo, and you can see the atropine group progressed less in terms of the measured myopia and the axial length change. It was also reported to be very well tolerated in their study. ATOM 2, so this is in 2012. 355 of 400 children completed this 2-year study. They had different groups, so it was 0.5%, 0.1%, and 0.01%. And you can see from the numbers here that the myopic progression was less with the higher dose, but they're kind of similar and maybe not clinically significantly that different, and the axial length change similar. Importantly, the 0.01% had a negligible effect on accommodation and pupil size and no effect on near visual acuity. So the patients do not need bifocals. they just do well. They're going about their normal business with their regular glasses. Then there's an extension. So after a 1-year washout, the children who had myopia progression at least a half diopter were restarted on the 0.01%. And then over 2 years, you look at the overall progression from the initial groups, and you see the lower dose, the 0.01% with the lower dose, actually overall progressed less. So why would this be? Well, importantly, after you stop the drops, there may be a rebound where they're really getting a lot more myopia sort of quickly and catching up. But in this, the conclusion here was that the lowest dose had the least rebound progression and then responded best to the reinitiation of the low-dose atropine. So a meta-analysis in 2017 was done, 19 studies including over 3,000 children. And there weighted mean difference between the atropine and the control groups. You can see that, okay, it was about half a diopter per year for the low dose. It was a little bit more effective for the higher dose, but maybe that difference is not so important, especially because the adverse effects were much higher with the high dose. So in terms of photophobia, 43% in the high dose. So we're talking, I mean, we dilate our patients every day. They go out of the office and they're pretty uncomfortable from the light. People don't want to be dealing with that every single day. But in the low dose, it was only 6%. There was no difference in the adverse effects between the Asian and white patients, which I want to talk about a little bit more later. Okay. So the other side effects. In the ATOM 2, after the 2 years of treatment and 1 year of washout, the accommodation was less in all of these groups than in the baseline, and there was more of an effect with the higher dose group. So we do need to see longer follow-up to see the long-term effects. IOP, no significant changes, no readings of more than 21, so I don't think this is something we need to worry about. So this is an important point that I do hear people bring up a lot, that most of these studies were done in the Asian populations. How does that compare to our populations at home? A meta-analysis did show that atropine may have more an effect on Asian children, and there have been no randomized controlled trials outside of Asia. But there have been smaller studies. So a retrospective study of 60 children showed a significant reduction of myopic progression in a mostly white population. And other small studies have been done in these different places. But unlike the very well-designed ATOM studies, they do have limitations of size and design. So maybe we still need to look into that. Just to mention some new things that I saw while researching to put this together. The idea that maybe the medication could actually be delivered through contact lenses. So if we want to get, if we want to get the effect of multiple modalities at the same time, that could be an option. Really importantly, this is not approved by the FDA. I use this Shady Grove Pharmacy in Maryland. They do it by mail order. Recently, the prices went up pretty much everywhere because I called around a lot of places to see, and they're all kind of hovering around the same, but it's about $90 for a 2-month supply and typically not covered by insurance. So the cost can also be a factor to consider. For future research on this, better understanding of the mechanism, application to non-Asian populations like we talked about, what is the optimal dosage? Could we go even lower? And what's the optimal age and length of treatment? Usually I tell patients this is at least a year or 2 years. It may be even longer. So, you know, all of those need to be sort of more fine-tuned. Okay, my references, and I don't know if you want to entertain questions now. Or, okay, if there's any questions.
Would you care to speculate on the mechanism of the axial elongation, knowing that the dopamine and muscarine agents is secreted in the retina, like the amyloid horizontal cell?
And Jamie, if you could repeat the question, we are doing a live recording and it's streamed, so that way they can hear it.
Okay, so the question was some specifics about the mechanism based on the dopamine. I can't really speak more to that than I mentioned already. If someone else knows something about that, I'd be happy to learn. Yes?
Just a quick question. I know often you pointed out the accommodation seems to not be effective, but it's hard if you just kind of think about what happens, like if you take a balloon and put a belt around it, it's hard to kind of ignore the biomechanics almost. If you have a ciliary body that's constantly constricted,
Yeah, like a scleral buckle.
Right.
Yeah.
So, I mean, I don't know if there would be a way to, it's just hard to ignore that and say there's no chance that, I mean, I get that the accommodation, it's associated with maybe with more of the dopamine release and all these things that cause the tissue to change maybe, but is there not a force there that's actually maybe what's responsible for all of it?
So the question is there a force responsible for making the eye longer?
Correct. Through accommodation, like is the accommodation actually creating that vector?
And how that relates to the atropine?
No,
Is
and how that
oh.
may be the reason that the near work is associated with more, and when they go outside and they're looking far away, they have a lower incidence of myopia.
Yeah, well, I think that is the concept of the near work is that all that accommodation is making the eye longer and longer. Yeah, I think that, but it has, that's the sort of theory about it, but I think it has yet to be sort of exactly proven. Yeah.
What was the frequency of application of the 0.01% drops in these patients?
That's every night.
Just one drop a night.
One drop in each eye every night. Oh, and I also wanted to mention, so usually I offer this if they've progressed more than a diopter in a year. Less than that, I don't think it's worthwhile because of the changes that you see. It's not really worth it, the effect.
I wonder, the children's eyes are usually hypermetropic. There is a growth into myopia. My question would be, why this change into myopia? I understand that the globe is going to be larger as time goes by, as time passes, but do we really understand what is the biology of the growth of the eye? What are the factors that produce these? Because perhaps all what you mentioned is in the periphery and not in the essence of what is happening.
Yeah, I think we actually don't understand it as well as we need to. And that's why there's confusion about why does it sometimes get even longer and why can these different things effectively slow that? Because there are some gaps in our knowledge there. Okay, thank you.